Okay, Sriniwas, you are ready?
Yes, sir.
Okay, start. Morning.
Good morning, everybody. I'm presenting a case of a 48 years old female patient who is a resident of Churu, Rajasthan, who is a homemaker by profession, presented with the chief complaints of yellowish discoloration of eyes since 1.5 months, associated with loss of weight and appetite since 1.5 months, itching since 1 month. Patient was apparently all right since 1.5 months ago when she developed yellowish discoloration of eyes and urine associated with clay-colored stools. The jaundice was progressive, non-waxing and waning, associated with nausea. She also gave a history of vague abdominal pain in right upper quadrant since 2 months, which was dull aching, continuous, mild in intensity, non-radiating or migrating, not related to food intake or postural variation, and had no specific aggravating or relieving factors. Patient also developed itching for the past 1 month all over the body. She gave a history of loss of appetite and an unquantified loss of weight since around 1.5 to 2 months. She gave a history of low-grade fever associated with chills 15 days back, which lasted for 4 days and was relieved with medication. She went to a local hospital and underwent an ultrasound abdomen and was referred here to our center. There was no history of abdominal distension, vomiting, hematemesis, or melena. No history of constipation or diarrhea. No history of any blood transfusion. No history of usage of any native medications. Past history, no similar histories in the past. No history of any blood transfusion or known viral diseases. No history of diabetes mellitus, hypertension, coronary artery disease, TB, or cardiovascular events. She's known hypothyroid since 10 years and on medication. She underwent appendicectomy in 2006 and tubal ligation in 2000. Personal history, she is not a smoker or alcoholic. She takes normal mixed diet with disturbed sleep and appetite, which is decreased. Bladder habits were normal. There was no significant family history, no drug or allergic history. Summarizing my case, a 48 years old female with progressive jaundice since 1.5 months associated with pruritus and loss of weight and appetite and with clay-colored stools. Had one episode of fever 15 days ago, which resolved on medication without any comorbidities. Differential diagnosis for my case is a surgical or obstructive jaundice, probably a carcinoma head of pancreas, a carcinoma gallbladder, or a distal cholangiocarcinoma, sir.
So why do you say that this is malignant jaundice?
Sir, because it is a short duration jaundice and it was vague pain was there, not a specific sharp pain as described by the patient, sir.
Yeah, put your video on so that we all can see you.
Sir.
So what do you mean by vague pain? How is vague pain and sharp pain? What exactly are you trying to say?
Sir, this sharp pain basically is associated with either previous episode of cholecystitis episodes, sir.
So at this level, I will accept if you say that the pain doesn't look like biliary colic.
Okay, sir.
That's okay. I think most of the examiners will at this level accept that. If you say that to me, the pain doesn't look like biliary colic, it is a dull, diffuse pain. Okay.
Okay, sir.
So what are the points in favor of malignant jaundice? Can you enumerate them?
Sir, short history of presentation, that is 1.5 months. It was vague pain, not a sharp pain, not a biliary colic. Then associated with loss of weight and appetite. There was also a colic type of stools, which was noted by the patient, sir.
So you mean if a patient presents with 1 month history of jaundice, it cannot be benign?
Sir, less likely it can be benign.
Right?
There are chances wherein like if there is a cholelithiasis which might have resolved out, or if there is a compression because of a duodenal diverticula, it can present with such scenarios. But however, it is less likely, sir. Looking at
the patient with CBD stone develops jaundice and comes to you next week. Does it mean that it cannot be benign?
No, sir.
See, most of you get it wrong.
Sir.
Short duration is not a point in favor of malignancy. Long duration may exclude a diagnosis of malignancy. Suppose a patient says that I've been having jaundice recurrent episodes for last 2 years, it is unlikely that it is malignancy. If a patient with benign disease presents to you immediately after the onset of symptoms, it doesn't mean that it cannot be benign. So that is not a strong point in favor of malignancy. What is the strongest point in favor of malignancy?
Sir, painless jaundice. Like
progressive jaundice.
Progressive jaundice. Sir.
Jaundice. What are the common causes of benign jaundice, benign surgical obstructive jaundice?
Sir, for benign surgical jaundice, sir, first is choledocholithiasis, sir, or any biliary strictures, or it can be because of like lower down, there can be a duodenal diverticula, or there can be associated with hemobilia.
Common. How many duodenal diverticulae causing jaundice have you seen?
Sir, only ampullary duodenal diverticula is known to cause out. Else, it is rare, sir.
That also is very unlikely. More common than that, something which you see in young adults, children, even adults. Choledochal cysts.
Choledochal cysts.
These are the two common causes. Even biliary stricture would be less common. So choledocholithiasis and choledochal cyst, and in both these conditions, the jaundice is intermittent.
Intermittent jaundice. Sir.
It is not progressive jaundice. So progressive jaundice is the strongest point, plus anorexia and weight loss. Although you have to remember that any jaundice, whether it is obstructive or hepatic jaundice, can cause so much of anorexia that it can result in some weight loss. So you have to keep that in mind. But a middle-aged patient with progressive jaundice, not associated with pain, which is typical of biliary colic, significant anorexia and weight loss, these are the points in favor of the malignant cause of jaundice. Okay?
Yes, sir.
Now, you said your first diagnosis is CA head pancreas. Why do you say so?
Sir, first thing is that it was a progressive jaundice, sir, unlike a waxing and a waning pattern. Second thing is that
progressive jaundice is not a point in favor of CA head pancreas. Now we have discussed that it is malignant or jaundice. Now you have to give me the points which support the diagnosis. Even in gallbladder cancer, jaundice will be progressive. Even in cholangiocarcinoma, jaundice will be progressive. Give me points in favor of your first diagnosis as CA head pancreas.
Sir, incidence of CA head pancreas compared to like it is more commoner compared to CA gallbladder, sir.
Okay. So put it the other way, that more patients with CA head pancreas will have pain than patients with CA gallbladder. So generally what I say that 2/3 to 3/4 of patients with CA head pancreas will have pain, which means that even 1/4 of patients with CA head pancreas may not have pain. Gallbladder, it is about 1/2 to 2/3. So if you have progressive jaundice and pain, these are the two possible or more common diagnoses, as opposed to cholangiocarcinoma and periambulary carcinoma, where the progressive jaundice is usually painless. So these are the 4 common causes of malignant surgical obstructive jaundice: CA head pancreas, CA gallbladder, periambulary, and hilar cholangiocarcinoma. So out of those 4, 2 are usually painless and 2 are more commonly associated with pain. Okay. Any other point in favor of CA head pancreas? Which is not there in this case, but if it was there, you would probably make a diagnosis of CA head pancreas.
Any palpable lump, sir?
No, we are only at history.
Sorry.
Yeah. Palpable lump is more likely to be in CA head or
sir, sir, it can be present in both, sir.
No, the patient palpating a lump and reporting it to you in history, which is in which organ it is more likely, which organ is more superficial?
Gallbladder is more superficial, sir.
More likely, if a patient has palpated a lump, it is more likely to be gallbladder rather than pancreas. So pancreas is a deep-seated organ. Unless the lump becomes very big, the patient may not be able to palpate it. So that is not a point. Point is, if the patient has symptoms of gastric outlet obstruction, duodenal obstruction, that is a point in favor of
CA head of failure.
If you have progressive jaundice, there is pain, then these are the two diagnoses. If the patient also has features of gastric outlet obstruction, it is more likely to be CA head pancreas. Although you must remember that even in CA gallbladder, duodenum first part may be involved and patient can have gastric outlet obstruction, but it is more likely in CA head pancreas than in CA gallbladder. And then statistically speaking, which is more common in our part of the country?
Sir, in our part of the country, CA gallbladder in the northern India, sir.
So if I were you, I would probably put CA gallbladder as the first, although both are okay for these reasons that statistically speaking, gallbladder is much more common than head pancreas. There is pain, which you said is in the right hypochondrium, not in the epigastrium.
Yes, sir. Yes, sir.
And the fact, yeah. So first analysis is malignant obstructive jaundice. Second is because there is pain, which is either gallbladder or pancreas. And for these two reasons, because statistically gallbladder is more common and pain is in the right hypochondrium, I would say gallbladder. Okay.
Yes, sir.
Any other faculty member would like to make any comment on the analysis of history, or any student would like to ask anything about the history? Anyone? Avinash? Okay, proceed. And if you are going to have an online exam and if you are making the presentation, I would suggest that you should add a slide of summary and a slide of differential diagnosis.
Okay, sir. General examination. Patient was conscious, coherent, well-oriented, oriented to time, place, and person, responding well. She was obese but well-nourished. ECOG status was 1. BMI was her BMI was 32 kgs per meter square. She had icterus with scratch mark present all over the abdomen and limbs. She had no pallor, cyanosis, clubbing, or pedal edema. No generalized or supraclavicular lymphadenopathy. No signs of liver failure. Patient was afebrile with the pulse rate of 78 per minute. BP was 130/80. Respiratory rate was normal. Breath holding was 45 seconds. Abdominal examination. Abdomen was distended with all quadrants which moved equally with respiration. Umbilicus was normal, centrally placed, and inverted. No lumps or no masses seen beneath the umbilicus. No scars, no sinus, no dilated veins, abnormal pulsations, or visible peristalsis noted. Scratch marks were noted over the abdomen and the back. Flanks were free. Hernial orifices appeared normal. Back in the spine was normal. There was no supraclavicular fullness. Upon palpation, abdomen was non-tender. There was a non-tender palpable lump in right hypochondrium, which was globular in shape, approximately 8 into 5 centimeters, with smooth surface extending below the costal margin. It was lateral to the lateral margin of the rectus towards the right subcostal region. All the margins were well defined except the superior margin. Mass was firm in consistency, moving with respiration, and no intrinsic mobility. There was no hepatosplenomegaly, no organomegaly, no fluid thrill or shifting dullness. The liver span was 11 centimeters.
एक ER वार्ड है, सर्जिकल वार्ड, फिर एक F4 है और फिर E4 है, 4 है मेल वार्ड, फीमेल वार्ड 2 है.
Liver span was 11 centimeters. There was no normal bowel sounds which were heard. Perrectal examination was normal with clay-colored stool. Perrectal examination had clay-colored stools. No pelvic deposits noted. All other system examination were normal. Spine and cranium was normal, sir.
When you mentioned supraclavicular nodes.
Yes, sir.
Which supraclavicular node?
Sir, Virchow's node, sir.
Left, huh?
Left supraclavicular, sir.
Say that specifically, left
Sir.
supraclavicular. Because in an intra-abdominal malignancy, it is the left supraclavicular.
Yes, sir.
Now, Dr. Angeline has a query that are you sure that breath holding time was 45 seconds? You have mentioned that obese lady able to hold breath for 45 seconds. But this was provided to you.
Sir, breath holding was already noted, sir. Actually, I didn't personally note it.
Okay. Yeah, because she's right that it is very unusual for an obese lady to have a breath holding time of.
Sriniwas,
Sir,
in your presentation, you have written albumin lump in right hypochondria.
yes, sir.
That's good enough. Why are you specifying further, elaborating that it is on lateral to the lateral border of rectus? Right hypochondrium is always lateral to the lateral border of rectus.
Sir.
So don't. This is just the state. Superfluous addition to your listing. Try and register using any adjective or any extra things when you are presenting, particularly in exams.
Sir.
Okay, and the stool examination, you mentioned clay colored stool. What else were you looking for in the stool?
Sir, pelvic deposits, Kirkenberg's tumor.
In the stool.
In this setting, what else were you looking for in the stool?
Sir, if there is presence of any melena or not.
Yeah, so say that there is no melena. See,
Sir.
Even negative findings, when you mention, you should mention the important negative findings also. Okay,
Sir.
it tells me that what is going on in your mind and what are you thinking. So, which of the causes that we discussed of malignant surgical obstructive jaundice, there could be melena?
Sir, it can be noted in case of periampullary type of malignancy, periampullary CA, or it can also be noted.
Periampullary CA.
Sir.
What is periampullary? What do you mean by periampullary?
Periampullary CA is a constellation of 4 malignancies arising at the level of ampulla at 2 centimeters in the circumference of, 2 centimeter radius of ampulla. These 4 can be either a duodenal malignancies, carcinoma head of pancreas, pancreatic duodenal adenocarcinoma, or a distal cholangiocarcinoma, sir.
Yes, partly right. The correct definition is that periampullary cancers is a group of cancers which are situated around the ampulla. Ampulla is the common channel formed by the lower part of the common bile duct and the terminal part of the pancreatic duct. It is called ampulla because it is little dilated as compared to the 2 ducts. That is the meaning of ampulla. Ampulla then opens on the medial wall of the second part of duodenum at the papilla. These are 2 different things. A lot of textbooks confuse between these 2. Papilla is the opening. Ampulla is the common channel. So periampullary tumors are, some people say 1, some say 2 centimeters around the ampulla. They include a lower end cholangiocarcinoma, distal cholangiocarcinoma. They include a small pancreatic ductal adenocarcinoma, which is arising from the terminal part of the pancreatic duct. They include a papillary carcinoma, which is at the papilla, which is what you will see when you do side viewing endoscopy. An ampullary carcinoma will not be seen on side viewing endoscopy. A distal cholangiocarcinoma will not be seen on side viewing endoscopy. And a peripapillary duodenal carcinoma. So out of these, which is more likely to have bleeding?
Sir, a papillary type of papillary carcinoma is more likely to have a bleeding, sir, because of sloughing of mucosa.
Most likely the duodenal, the peripapillary duodenal followed by papillary. These are the 2 lesions which will have melena. And in papillary carcinoma, textbooks describe that you could have episodes of melena, which is because of the sloughing of the tumor, and that sloughing may cause temporary relief of biliary obstruction. So jaundice may be waxing and waning, although that is not characteristically seen very frequently. It's a very small number of cases it is seen. So duodenal carcinoma and papillary carcinoma can give rise to melena. Similarly, CA head pancreas, large mass which is infiltrating the duodenum can cause melena. CA gallbladder which is infiltrating the duodenum or the hepatic flexure or proximal transverse colon can cause melena. But a cholangiocarcinoma or a head pancreas which is not infiltrating the duodenum, and ampullary carcinoma usually will not cause melena. Okay, go back to the palpation. What is your interpretation of this slide?
Sir, this is a enlarged gallbladder, sir, distended gallbladder.
Why do you think so?
Sir, because first thing is that it is a globular mass with a smooth surface, firm in consistency. The other thing is that all the margins except the superior margin was not palpable, and the mass was mobile with respiration, sir, and no intrinsic mobility was noted.
A GB lump could be either a distended gallbladder, the description he has given here, or it could be a GB mass in gallbladder cancer, which will be firm to hard, may not take the shape of gallbladder, and although it will move with respiration, but it will not have intrinsic mobility. You have to remember that a distended gallbladder need not necessarily be soft. If it is very tense, it can be firm. And the two may be difficult to differentiate from one another, which will be obvious only on ultrasound. So what do you think is the cause of this distended gallbladder?
Sir, this follows out a Courvoisier's law, sir. I would suspect out a CA head of pancreas causing out a distal obstruction leading to filling of this gallbladder, sir.
Only CA head pancreas will cause distended gallbladder?
No, sir. Like in case of there are exceptions to this also.
No. In addition to CA head pancreas, what
sir,
else
distal,
will...
sir, distal cholangiocarcinomas.
Any distal.
Any distal
malignancies. Say that in this setting of malignant surgical obstructive jaundice, a distended gallbladder means that the block is at the lower end, which could be either CA head pancreas or it could be a periampullary carcinoma. Could the block be anywhere else other than lower end?
Sir, it can be at a higher level also. It can be a GB malignancy obstructing at the neck of the gallbladder, or it can be a slightly proximal cholangiocarcinoma with a distant extension, sir.
How will you have a distended gallbladder in a proximal cholangiocarcinoma? What do you mean by proximal? Is there a term called proximal cholangiocarcinoma?
No, sir. Actually, like when we say a distal cholangiocarcinoma, anything which is below the cystic duct junction is distal cholangiocarcinoma, sir. This can occasionally be a hilar or like a common hepatic which can extend downwards, causing out an obstruction at cystic duct, sir.
No. So what you should say that gallbladder can be distended. Most commonly, it is distended when there is a lower end block, which is head pancreas or any of the periampullary cancers. They are all same. It could be distended if there is a neck tumor in the gallbladder because the cystic duct is blocked. Then it could be distended if there is a mid CBD cholangiocarcinoma which is blocking the cystic duct. A proximal or a hilar cholangiocarcinoma will not give rise to a distended gallbladder. Now, the terminology of cholangiocarcinoma, there is a little bit of confusion, but by and large, they are intrahepatic and extrahepatic. Intrahepatic is what is known as also cholangiocellular carcinoma, CCC, which behaves and presents and is managed almost like HCC because it is all in the liver. Then you have a term called perihilar cholangiocarcinoma. Some people use the term perihilar. Perihilar means hilar as well as above the cystic duct. On the other hand, other texts use only the term hilar. Hilar means involving the biliary ductal confluence. So there is confusion between these two terms. And then you have the term called extrahepatic cholangiocarcinoma, which also includes hilar, mid and lower end cholangiocarcinoma. Lower end cholangiocarcinoma is usually taken as a part of a periampullary tumor. So these are different terms which are used. There is no standard terminology, but you should be clear about them. Okay? Yes, fine. So after the examination, what is your diagnosis?
Sir, after examination, sir, my diagnosis persists with the same, sir. That is CA head of pancreas, or it can be a distal cholangiocarcinoma or a CA gallbladder, sir.
Yeah, but because of the pain, we thought that pancreas and gallbladder are more likely than a cholangiocarcinoma.
Cholangiocarcinoma.
Cholangiocarcinoma usually is a painless progressive
Painless.
jaundice, whether it is distal, mid, or proximal. Because pain in all these malignancies is not because of the tumor, it is because of the infiltration of the adjacent organs, which is not there in a cholangiocarcinoma. It comes much late. So cholangiocarcinoma usually is painless progressive jaundice. Periampullary carcinoma usually is painless progressive jaundice. And it would basically be pancreas or gallbladder. As I said, that because of statistics and because of the pain being in the right hypochondrium, I would say gallbladder, but gallbladder neck causing pain again is unusual because the tumor is usually small. It presents with jaundice. So I at this stage, I may agree with you that pancreas, head pancreas is more likely than gallbladder. Okay. Any faculty member at this stage would like to make any comment? Any student? Any questions? Any doubts? So I hope this analysis of jaundice and obstructive jaundice and malignant obstructive jaundice is clear in your mind, and that is how you should discuss or analyze. It could be anything, but your points in favor, points and against should be clear. Okay, fine. So this patient comes to you in the OPD. What will you do?
Sir, as the patient had a previous episode of fever 15 days ago, which was resolved with medication.
A very common mistake which all of you do. When a question is asked, give the answer first and give the reason or justification or explanation later. I'm waiting to hear what will you do. You are giving me the justification. So please, all students, all of you do this mistake. Please answer the question first and then give the explanation. Yes.
I would like to first optimize the patient. Along with simultaneously, I would like to evaluate.
So what optimization does she need? What behavior does she have?
Sir, I would like to check her. I would like to advise or request for her total blood count.
That is not optimization. You said I would like to optimize. Optimization is when a patient is dehydrated, when a patient is having electrolyte imbalance, when a patient is having altered sensorium, when a patient is hemodynamically unstable. She has nothing like that. She's an elective case who comes to OPD, walks into your clinic. What optimization? So use your words very judiciously, very carefully. Okay? Yes. Go back to the question again. What will you do?
Sir, I would like to evaluate. I would like to first review her old report, sir. She has undergone an ultrasound, so I would like to review her.
Nothing is available.
I would like to request for investigation, sir. I will request a hemogram, including her hemoglobin, total count, and a differential count with LFT, liver function test, along with PT-INR and renal function test with electrolytes, sir.
Why do you want a hemogram?
Sir, hemogram, the patient had, first is to check her hemoglobin status. And then followed by that, the patient had 15 days ago episode of fever, which resolved with medication. Probably she might be having currently subclinical cholangitis. So I would like to evaluate that.
Although at the moment she is afebrile, isn't it?
Yes, sir.
And the fever settled almost 2 weeks ago. So very unlikely that hemogram now would show anything. Okay. Fine. So we have these reports?
Yes, sir.
Let's see. So I quickly want to move on to the management.
Ultrasound abdomen was done, sir.
Sir. No, first show us the hemogram. LFT.
Hemogram, sir. Yes. Hemogram, sir. Hemoglobin is 13.6 grams per deciliter. Total leukocyte count is 14,000, sir, with a platelet count of 5,88,000. Suggestive that the patient is currently under sepsis, probably a cholangitis ongoing, sir, which is subclinical.
So is that a complete report, or you would like to know something more in the hemogram?
Sir, I would like to also note the total leukocyte, the differential count also, sir.
So whenever you present a report, if a report has been provided to you and you feel it is incomplete, you should yourself point it out that this is missing in this report. Again, it tells me that what you wanted. Otherwise, I think that you are all right with this report, which is not true. You would like to know the differential count.
Differential
also.
count.
Okay. Next investigation, blood.
Sir,
LFT.
LFT, sir. Her total bilirubin was 3.8 with direct of 2.8. There is deranged liver enzymes with alkaline phosphatase, which is elevated. Nutrition status appears to be normal with albumin of 4.
We don't see your slide. Are you projecting some reports?
Yes, sir.
No, we are not seeing.
We are not seeing your investigation reports.
Just share that. No, we only see your number 7 slide. Liver scan.
Oh, sir, 1 minute, sir.
Yes, now we see. Okay.
This is her hemogram, sir. Liver function test, bilirubin was 3.8, total of 2.8, with there is deranged liver enzymes. Alkaline phosphatase is 384, which is elevated. Her albumin is 4.1, which is nutritionally normal, well preserved. GGT is marginally elevated, sir, 94.
So what do you make out of this LFT?
Sir, by this LFT, I make out is that patient is currently in, there is an obstructive jaundice, definitely a parameter of obstructive jaundice, along with slight derangement of LFT, sir.
So that can happen in obstructive jaundice.
Sir?
Yeah, please.
That can happen in obstructive jaundice. That
Yes,
much of, yeah, this is just, say, GPT is a little more increased.
So why do you say that she is in cholangitis, subclinical?
Sir, for, one thing is that total total count is elevated, sir, with platelet, which is also elevated. Along with that, there is some marginal liver enzymes derangement, sir.
Yeah, not marginal. SGPT is quite high, 40. Most labs will have an upper limit of 40, so it is 5 times high. It is significantly high, isn't it?
Sir.
Significantly high. Okay. Okay, fine. Next, what investigation do you want?
Sir, I would also like to see her PT-INR status. Coagulation profile. Oh, sorry. PT-INR is is missing, sir, with the slide.
Okay, let us presume it is 1.4.
Sir, PT-INR is in a high INR is in high normal region, sir. I would like to also, since the patient is having a symptom since 1.5 months, I would like to advise for a vitamin K also. Along with that, I'll go ahead with the tumor marker CA99, sir.
So that is your clinical diagnosis. You have not still confirmed that she has a tumor. So why do you want to do a tumor marker first? These are all expensive investigations. Tumor marker should come after you have demonstrated that there is a tumor. We have still not confirmed that there is a tumor.
I will, sir. I'll check the renal function test. Her creatinine being normal, 0.5. I'll advise her to go for a triple phase CCT, IV or IV contrast pancreatic protocol, sir.
CT shows multiple large bilobar liver metastasis. Could you have preempted that?
I didn't get you, sir.
CT shows large multiple bilobar liver metastasis.
Yes,
now,
sir.
Would you regret your decision to get a CT scan done directly?
Ultrasound, sir, I will see.
You didn't do an ultrasound. All HPB malignancies, you must do an ultrasound before you go for CT scan. Colorectal malignancies, there may be a debate. Some examiners may say that why do you do an ultrasound? Because whatever ultrasound shows, still you will do treatment of primary. So there may be a debate there, which we can discuss when we are discussing a colorectal case. But all HPB malignancies, you must do an ultrasound, because in all HPB malignancies, if you see a liver metastasis, even if it is single, even if it is small, even if it is close to the primary, if it is proven to be metastasis, most people will not go ahead with resection. So ultrasound in HPB malignancy is a must. You cannot do away. And in the same breath, I will say a chest X-ray. So whenever you are dealing with any malignancy, it is much safer to say an ultrasound and a chest X-ray as the first investigation, and then move on to expensive or invasive investigations. So don't forget that.
Sir.
Most of you don't mention chest X-ray, and many of us will insist on this because it's a simple, suppose chest X-ray shows a lesion, coin lesion in the chest in an HPV malignancy, nobody is going to proceed further. So what does the ultrasound show?
Ultrasound abdomen shows normal size of lesion.
Yes.
Patient has grossly dilated CBD at porta with proximal IHBRD, and intrapancreatic CBD is narrowed. Pancreas head, bulky head and uncinate process mass of around 3 into 2 centimeters, which is hypoechoic. Rest of the pancreas is normal, no ascites, no any other mass lesions. Gallbladder is grossly distended, sir. Sir, suggestive of a pancreatic head mass of 3 into 2 centimeters with obstruction of CBD with proximal IHBR, sir.
Is there something which is not fitting in this report with the interpretation? Or everything is fitting in? So you are saying this is a tumor in the head of the pancreas?
Sir, there is no mentioning about MPD, sir.
One is that there is no mention of MPD, and other, if you have a tumor in the head of the pancreas, what is the, they have said CBD dilated at the porta. What do you expect in CA head pancreas?
Sir, sir, they have mentioned intrapancreatic CBD is narrowed, they have mentioned, sir. Diameter at porta, they have mentioned of as 17 mm, sir.
Yeah, you expect that CBD will be dilated in the entire
course.
Hepatic extent, isn't it?
Yes, sir.
So that is the usual finding. Here, it seems that only at the porta. Porta means where the two ducts are joining. Below that, they haven't seen the CBD, which is very unlikely because the CBD in the hepatoduodenal ligament also should have been dilated. So it is little incongruous with that. Okay, what next?
Sir, I would like to go ahead with a tumor marker.
Suppose that lesion in the head of the pancreas was not reported. Then what would have been your interpretation? Rest
Sir,
of the report is like this.
In that case, I will suspect it to be a distal cholangiocarcinoma, sir.
Why
like
distal?
Distal cholangio, because there is CBD which is dilated at the porta. They have not mentioned the lower part is.
Yeah, but if it is not mentioned, we presume it is not dilated. So CBD dilated at porta, pancreas is normal, gallbladder is normal. What would be the diagnosis on ultrasound? Then you are dealing with a proximal cholangiocarcinoma, as you said, hilar cholangiocarcinoma.
Sir,
so another thing missing in this is that whether the confluence is formed or not.
Sir, they have mentioned that gallbladder is grossly distended already, sir.
Oh yes, sorry.
But then that could
I
be
missed that. So probably a mid CBD. Yeah, you are right. Mid CBD cholangiocarcinoma. And also you cannot rule out a GBC neck because
Yes,
GBC neck, if it is small, it will cause jaundice, it will cause a distended gallbladder, and it can be missed on ultrasound. Ultrasound may not pick up every small lesion in the gallbladder. So that also is a possibility. Yes, you are right. Okay. So now with this ultrasound report, what next?
Sir,
Sorry. Dr. Anand wants to say something.
Is your history or examination finding what is a lump in the right upper quadrant?
yes,
When
sir.
we examine the patient, such a case, when the gallbladder is distended, it is a smooth, distended lump at the right upper quadrant. This is not a lump. Basically, it's a gallbladder lump. And you have explained in your examination as a lump palpable at the right upper quadrant. We are misinterpreting this as a CHB.
Okay,
So we should be very careful when the lump, smooth globular lump at the right upper quadrant, we'll directly say the palpable gallbladder at the right upper quadrant. We will not speak a palpable lump at that.
So say that it is a distended gallbladder, not a GB mass.
Yes, sir.
Okay.
At MCH level, though you said in your confession, you have written that it is a smooth and Professor Kapoor discussed it, and that time you clarified. But what Dr. Anand says is correct, that at MCH level, you see the patient is same, findings are same in MBBS. If the presentation by a MBBS student, MS student, student differs a bit. Here you can say, and the examiners also will take it if you straightway say that because you are presenting and you have already made a diagnosis, clinical diagnosis, and say. So you say that it is just a distended gallbladder.
Okay, sir.
Yeah.
Yeah. What is the importance of the MPD?
Yeah, Raj.
Yeah.
What are all the importances of the MPD? There are multiple ones.
Sir, MPD, if the MPD is like distended MPD, that means it can the obstruction can be at the ampulla level, sir, which means causing both like distension of both CBD as well as MPD. The other thing, clinically or surgical aspect also, MPD diameter of more than 5 mm will have lesser post-operative leak chances, sir.
What else? What about diseases? What diseases will the MPD be dilated?
Sir, it can also be dilated in case of pancreatic head carcinomas associated with chronic pancreatitis. MPD can be dilated, sir.
What else? With a head lesion, with a dilated pancreatic duct, what other possibility is there? Have you thought of IPMN?
Sir, IPMN, sir. But the age of this patient is 48, sir.
So IPMN is seen around that age only, starting from 40s,
sir,
extending up to the 60s.
Sir.
Again, you should not make your differential diagnosis based on age. The only situation where you may use age to either make or exclude a diagnosis is if it is a very young patient. Then you may say that it is less likely to be malignancy, although we all have seen all malignancies even in 20s and 30s. So don't make age as the point to make or to refute a diagnosis. Okay.
Sure.
So out of all the periampullary tumors that we earlier discussed, if you have a tumor in the papilla, if you have a tumor in the ampulla, if you have a tumor in the head of the pancreas, pancreatic ductal adenocarcinoma, that will cause a dilatation of the pancreatic duct. But if it is a pure lower end cholangiocarcinoma, which is not involving the ampulla, then the PD will not be dilated. So again, on ultrasound, most of the tumors can be diagnosed. In all patients, there will be IHBRD. If the two ducts are not joining at the confluence, it is hilar cholangiocarcinoma. If the two ducts are joining, but below that you don't see any dilated duct and the GB is distended, it is likely to be a GBC neck, which is causing subhilar obstruction and distended gallbladder. If you see IHBRD, CBD dilated till lower end, GB is distended, pancreatic duct is also dilated, and the two ducts are almost joining or approximating each other, and there is no mass in the head of the pancreas, then this is a periampullary carcinoma, ampullary or papillary. If only CBD is dilated till lower end, MPD is not dilated, there is no mass, it is a distal cholangiocarcinoma. If the two ducts are dilated, but they are not meeting each other, they are at a distance from each other, and you see a mass, then it is head pancreas. So in most cases, a good ultrasound can virtually give you the site of the tumor. As Dr. Rajan Desai said, you have only a hypoechoic lesion. We don't know whether it is solid or cystic. It is more likely to be cystic because it is saying hypoechoic, and you have MPD dilated. There is a possibility, not very common, but there is a possibility that it could be an IPMN, which has characteristic ductal dilatation. Okay. What next?
Sir, I would like to go. I would like to request her tumor marker. Before
How is tumor marker going to help you?
Sir.
And which tumor marker? PSA?
No, sir. CA19. Sorry.
So why
CA99?
Why say tumor marker? Say specifically what you want to do.
CA99 levels, sir.
How is it going to help you?
Sir, like it
Will it help you in making a diagnosis?
no, sir. Sorry, it is suggestive of a cholangiocarcinoma, sir. It won't help me. Sorry, it will be suggestive of malignancy, sir. It won't help in decision making per se.
Yeah. So see, when you are investigating a patient, there are three aims. One is to make a diagnosis. Second is to evaluate the patient for management. And third is some investigations which may help you in follow-up. So in most of these tumors, the tumor marker usually doesn't help you to make a diagnosis. It may, now since you have raised the point, in CA head pancreas, CA19-9 levels have been used by different groups for multiple purposes. One is to indicate whether a PET scan is required or not. If CA19-9 level is very high, most groups will go for a PET scan because that indicates that there is a metastasis. Second, it indicates the need for neoadjuvant treatment. If CA19-9 levels are high, most groups now would use neoadjuvant treatment to see the biology of the disease, to see the aggressiveness of the disease. Third, CA19-9 level may push you towards a staging laparoscopy if you don't believe in it as a routine in CA head pancreas, although many groups would use it as a routine, irrespective of the CA19-9 level. And fourth is to predict the prognosis because it indicates the outcome. So it doesn't help you to make a diagnosis. Some people may say that it may help you to differentiate between chronic pancreatitis and CA head pancreas. So in that setting, when you have an inflammatory head mass or you have chronic pancreatitis and you are thinking of superimposed CA head pancreas, there it may be one of the parameters which you can use to differentiate a benign from a malignant head mass. So I would suggest that in whenever you are discussing a case, CA19-9 should come after you have made a diagnosis rather than before. Same holds true in colorectal cancer. First you establish the diagnosis, then you say I will do a CEA. So what next will you do now?
Sir, I'll go for a CECT upper abdomen with IV contrast, pancreatic protocol, sir.
What is pancreatic protocol?
Pancreatic protocols are, sir, patient is given IV contrast. Along with that, a patient is asked to take water.
So is that enough to say that patient is given IV contrast?
Patient is first evaluated. Sorry, sir. The serum creatinine level of the patient is first.
No, that's all right. See, listen to the question. You said patient is given IV contrast. I asked you, is it enough to say patient is given IV contrast? I'm asking you about IV contrast now. I'm not asking you now about the suitability of the patient for CT. So in pancreatic protocol CT, is there any specific thing in giving IV contrast or it is just giving IV contrast? Are there any specifications?
Sir, films are taken in early arterial mode.
That is later. I'm talking of giving injection of the IV contrast. What I am trying to ask you is the volume of the contrast which is used, the speed at which the contrast is injected. There is a specific, it is a high volume. How much?
3 to 5 ml per second.
3 to 5 ml per second. No.
The speed of contrast is 3 to 5 ml.
But total volume?
Total volume 120 to 150 ml.
Yes. So large volume of contrast, Dr. Anand tells me 120 to 150 ml given at a high speed, 3 to 5 ml per second, which you cannot give with your hand. So you have to use a pump, an infusion pump or an injector. These are the things which you need to know and you need to mention. Okay?
Okay.
Yes. Sir. Then oral contrast.
Oral contrast. Orally, sir, only water is given, which acts as a negative contrast. Sir.
Negative contrast. Why do you do that?
Sir, artifacts can be produced because of oral contrast. If
I don't think that is the. Does oral contrast produce artifact? Normally, we give oral and rectal contrast. Does it produce artifact? I think check with your radiology colleagues, but I think the reason is that the duodenal wall delineation is better with oral, with negative rather than with positive contrast. But check with anything.
Anything else, sir? When we see the contrast in the artery phase, and same contrast in the stomach, so that some misinterpretation will be there. The one thing is
okay.
This is the artifact.
Okay. So what Dr. Anand is saying that if you give oral contrast, positive oral contrast during the arterial phase, the delineation of the vessels may not be as good if there is positive contrast in the lumen. So that is another reason why you give negative oral contrast. Okay. So pancreatic protocol CT. Let's see the CT. I would request all my young faculty colleagues in the group to please chip in. Please keep making comments. Yes.
But see, Sriniwas.
Yes,
I
sir.
wanted to ask Srinivas about the phases in which we take the at the what seconds we take the film.
Could you please repeat? I think he has not heard you.
Hi, Dr. Srinivas, I was
Yes, sir.
asking, you were saying early arterial phase. Does we take early arterial phase in pancreatic protocol?
Sir, we take it in arterial phase and venous and late venous, sir. 3 we take.
No,
In-
dear, it
in
is not
which-
like that.
In which phase the pancreatic parenchyma is best seen?
Arterial phase, sir.
Delayed arterial. That is what is
Late
called
arterial phase.
Late.
Yeah. That is what is called pancreatic parenchymal. So it is little later than arterial phase and little earlier than portal venous phase. Okay.
Okay,
And
sir.
there are
Yes, sir, rightly said.
specific time intervals between the injection of the IV contrast and the phases.
Yes, sir.
Yeah. Show us the CT.
The scout scan, sir. Is the film seen, sir?
Yes, we can see. Please.
This is a plain CT, sir. Excel images. Not showing any air or any calcifications or any ascites, sir.
There is a lot of air in the stomach and colon. You are saying I don't.
Sir,
Where are you looking at air?
Sorry, extraluminal air, sir.
Yes.
Image taken in arterial phase, sir. However, there is intragastric contrast is also seen, sir, in this phase.
So when you
here-
are given the CT, you should say that they have given oral positive
Oral-
contrast. I would not have liked to give this. I would have given a negative oral contrast.
Negative. Liver appears normal in shape. Contours are normal. There is dilated IHBR in intrahepatic secondary radicals also are dilated with a dilated CBD.
So immediately you should say that I can see the CBD dilated in the extrahepatic part also, which the ultrasound did not mention. It is dilated almost till the lower end.
Lower end, sir.
Even here it is dilated.
Yes, sir.
Yes.
Gallbladder appears to be distended, sir. Here, sir, the CBD is lost, sir. I'm not able to visualize the CBD below. This is probably the mass.
Where is the mass?
Sir, this one.
Normally in CA head pancreas on CT scan, the mass is what? What is the nature?
Hypointense, sir.
On CT, you use the word intensity.
Hypodense, sir. Hypodense.
Hypodense. So do we see? I don't know on the screen. I'm not. Yeah, here maybe.
Second thing is the comment on ICRT will be done in venous phases. So his comment has to be in. I'm seeing the ICRT. However, I would like to confirm on venous phases.
Yeah.
ऐसे लेना या तरीके से रख दे तो वही है।
Dr. Vinay is saying that the best place or the best film to comment on IHBR is the portal venous rather than
Okay, sir.
so
Arterial.
this phase is mainly for pancreatic parenchyma. Show the head pancreas again. I'm not sure if there is a mass.
Sir, this one.
No, in the head of the pancreas, there may be a mass in the go down from the dilated CBD to the go from above downwards.
Yes,
Show
sir.
the dilated CBD.
This
Yes.
is-
Now go down slowly. Yes. So this is where CBD is getting obstructed or
sir.
narrowed. But around this, I don't see, at least on the screen, I don't see a definite hypodense mass in the head of the pancreas. Rajan, anything? Any comment? Do we
I
see
agree
a mass?
with you that there is no clear-cut mass in the head of the pancreas.
I don't
One of
see
the
any.
questions is, has he considered IgG4 disease and has he considered chronic pancreatitis as the cause for this?
Do you think this could be chronic pancreatitis?
Sir, the patient did not
Less
have any...
likely because the duct is not dilated.
No, I'm asking Srinivas.
Sir, the patient clinically also did not present with any history of chronic pancreatitis before, sir.
And on the imaging?
Sir, imaging also, MPD was not dilated, sir.
So your answer should be that there is no history to suggest chronic pancreatitis. In the ultrasound, no calcification was seen in the pancreas. Pancreatic duct was not dilated. They did not report any atrophy of the pancreatic parenchyma. And on the CT also, in the plain cuts, I did not see any calcification. And here also, the PD is not dilated. So these are points against. See, some of these questions are asked to test your knowledge. We also know this is not chronic pancreatitis.
Sir.
But Dr. Desai asked you that question to know how you respond, how you answer the question. Okay?
Sir.
Yeah. So it's already 10 o'clock. I think we will have to stop. Any comments, any questions?
Just one last question. What is the features of CT on IgG4 pancreatitis? IgG4 disease, how would it present?
Sir, storiform fibrosis is present along with that sausage-shaped pancreas, sir.
Yeah, and it's surrounded by a rim.
And
hypoechoic rim.
The historical fibrosis is a finding of biopsy.
That's on biopsy.
Sausage-shaped pancreas could be the only finding. The contour and that grooves will be lost.
Just show the venous phase. Dr. Anand wants to see the venous phase. And Anand, in the meantime, you can make announcements for the next sessions, 1 or 2 sessions which we are planned. So next week, next week we will not have a session because we have IHPBA. The following week, Dr. H. Ramesh will discuss. So Dr. Anand has already announced the student who will prepare. So when you are preparing a session for operative surgery, you make presentation of indications, contraindications, preparation, procedure, and complications. So you will present, the student assigned will present, and the faculty moderator will moderate and discuss. And I have requested Dr. H. Ramesh to show us few small clips of videos to show you some crucial steps while doing LPJ or phrase procedure. And the following week will be necrosectomy by Dr. Rajesh Gupta from PGI Chandigarh. And we have some more faculty members slotted because I feel most of the times we don't discuss the operative procedure. So that is why I have planned these operative procedures specifically for you. And for today's session, students, if you send me a mail, I have already put my email address in the chat. Just write CAHOP in the subject. So I will send you the chapter on pancreas and pancreatic periampullary cancer. Yes, show the portal venous phase. Go down again on the CBD. What else do you see in addition to the CBD in the pancreas? To the left of the CBD, yes, here.
Sir, here there is SMV, sir.
Is this? No, the hypodense. Next, go up where the CBD is dilated. Yeah, to the left of that, you see the dilated pancreatic duct, probably of the uncinate process. But I don't see any mass lesion in the head of the pancreas. I would still feel this is a periampullary. There is some enhancement of the wall of the CBDC where it is getting narrowed. So
yes, sir.
Maybe it is a distal cholangiocarcinoma.
Okay.
Did they report a mass in the head of the pancreas on CT, the radiologist?
Yes, sir.
2 into 3 centimeters.
Okay. No, that was an ultrasound.
Yeah.
In the CT, what is the formal CT report, just for our knowledge?
What is aberrant? Do this patient having aberrant arterial anatomy?
Yes, sir.
But this is in the CBD. In the CBD.
कोलेंजियो होगा तो फिर एलपीडी को डायरेक्ट होगी
Yeah, show us the CT report.
Sir, is this report seen, sir?
Yes, yes, we can. They have reported a mass. Okay, fine. So another thing which you see on CT, once you have established the diagnosis and the cause of malignant obstruction, is the vascular anomaly, which should be very well seen on the arterial phase as it is here, because that then cautious you during the dissection in the hepatoduodenal ligament and behind the head of the pancreas. So on 19th, Abhishek Gautam from RML Lucknow will present. Abhishek, is he there? Are you there today? Anyway, we have already put this on the group. Dr. Anand has already put. On 26th, Dr. Bharat Sangal from KGMC will present surgery for pancreatic necrosis. And on 5th March, Dr. Govind from KIMS Trivandrum, I think will present shunt surgery for portal hypertension, which Dr. Biju will discuss. So we've already put, Dr. Anand has already put all this on the group. Yeah, and send me a mail today. Thank you. Thank you, Srinivas.
Thank you, sir.
Thank you, everyone. Thanks. We will close the meeting then.
Why you were late?